Hi, this is Jean Deschamps
and William Beaubien-Souligny
from the Université de Montréal. This is part of a series of video tutorials and reviews about venous congestion. This video will focus on the cardiac physiology and the intrarenal Doppler assessment. The 3 other videos of this series will deal with portal vein Doppler, hepatic vein Doppler, and integration of all venous congestion profiles. At the end of this video, you will be able to understand the basics of Doppler technique relating to intrarenal Doppler, understand the normal cardiac physiology and its impact on intrarenal venous and arterial flow, and understand pathological changes of cardiac physiology and intrarenal venous and arterial flow. One point that needs to be stressed early on is that the domain of intrarenal Doppler, particularly in the venous profiles, is progressing rapidly. As such, this topic is dynamic and subject to change. We will start with some basic technical and physiological concepts necessary for proper understanding of the assessment. Intrarenal Doppler has 2 components, the arterial and venous phases, which are often seen in the same image with proper positioning. These 2 waveforms are affected by multiple physiological variables. The analysis of the arterial waveform will often focus on the relative difference between the systolic and diastolic components. A high resistive index characterized by a low diastolic velocity in relation to systolic velocity can indicate reduced renal perfusion. However, there are many physiological variables that influence this relationship. Consequently, the use of the renal resistive index to assess renal perfusion remains controversial at the present time. In general summary, peripheral venous flow changes are intrinsically linked to changes in right arterial pressure during the cardiac cycle. Any changes in cardiac pressures are transmitted distally with some degree of attenuation. The major physiological point to remember is that normal right atrial filling should be throughout systole and diastole, with no reversal except for atrial contraction. The major abnormal physiological concept is that increasing right-sided pressures lead to impaired filling in systole, with predominant filling occurring in diastole. This may lead to complete absence of filling during systole, which is reflected in the peripheral venous system. While the hepatic vein tracing directly reflects cardiac pulsatility in the healthy individual, it is not the case in the distal venous system. While venous pulsatility is dependent on backward transmission of right atrial pressure variations, this transmission is usually minimal in distal organs. This attenuation of the venous pulse with increasing distance from the right atrium is related to the high compliance of the venous system. In the normal patient, the signal is usually monophasic with only slight, if present at all, S and D waves. Conversely, as the distended venous system becomes stiff, transmission of the right atrial pressure variations during the cardiac cycle increases. This represents the basis of abnormal Doppler findings in the portal, intrarenal, and femoral veins. If you've seen the previous 2 videos of this series, you will note that there are some significant differences in flow pattern between hepatic vein and portal vein patterns. Intrarenal Doppler profiles initially does not resemble the triphasic pattern of the hepatic vein, but as right-sided pressures increase, this triphasic pattern will emerge. The interpretation of the intrarenal venous Doppler waveform will be more like the hepatic vein profiles than the portal vein waveforms. This is because of the direct connection to the right heart without any shielding from the liver. This allows less dampened transmission of the pressure with increasing venous system rigidity.
We will now do a review of the technical acquisition principles for proper intrarenal Doppler assessment. Intrarenal Doppler assessment is performed within the kidney parenchyma at the level of the interlobar vessels. The artery and the vein travel in close proximity in this region. To adequately visualize interlobar vessels, it is important to adjust the color Doppler scale to detect low velocity signals in the range of 10 to 20 cm per second. The movement of the kidney during respiration can complicate the Doppler assessment. When a respiratory pause is impractical, it is useful to position the sample volume at the area where the vessels stop during the end of the expiration. Please note that the right kidney is often easier to assess due to the presence of the liver acting as an echographic window. Intrarenal Doppler is probably the most technically challenging of all venous congestion assessment techniques. There are three main reasons. First, the vessels being imaged is quite small. Second, the area to image can be difficult to assess. Third, this area is subject to major shift of tissues when breathing. In combination with small vessels, this may lead to the interrupted signal acquisition that is incompatible with proper interpretation. Furthermore, intrarenal Doppler assessment usually becomes more challenging in the context of shock, when renal perfusion is impaired, or when significant severe acute kidney injury is present. Success rate may vary from 70 to 90% in critically ill patients, even in experienced operators. There are also some technical considerations, both from Doppler aliasing and structural changes that cannot be visualized by 2D echo. One of these is arcuate arteries that may lead to negative velocities. This problem may lead to an incorrect assessment of the biphasic venous flow pattern.
In the next section, we will discuss the normal and abnormal intrarenal venous Doppler flow patterns. In the healthy individual, the intrarenal venous Doppler profile is usually continuous, but sometimes a brief interruption during atrial systole may be seen. In this form, the S and D waves are usually hard to completely differentiate, but this may be easier than in the portal vein flows. The profile becomes biphasic as a right atrial pressure increases, reflecting increased transmission of cardiac pulsatility in a stiff venous system. As can be seen, the S and D waves are better separated, and these correspond to the hepatic vein S and D waves. There are two interruptions of flow during the biphasic stage. The first one is during atrial contraction, where there is reversed flow in the venous system. This would correspond to the AR waves in the hepatic veins. The second is during the asiovolumetric relaxation phase immediately after the ventricular systole, which corresponds to end diastole with maximal RA filling. Overall, this pattern approximates the normal hepatic vein flow. There is initial preservation of flow during ventricular systole, represented by the S wave, and diastolic flow, represented by the D wave. However, with increased right atrial pressures, the S phase will disappear in accordance with interrupted flow during ventricular systole. The Doppler profile adopts a discontinuous monophasic profile with only diastolic flow, represented by the D wave, in advanced congestion. This closely approximates the severe hepatic vein congestion profile, although the reverse S wave is usually not seen except in very rare cases.
Quantification methods have been proposed. The renal impedance index uses the relative venous velocities as shown in the formula. While this provides a quantitative evaluation, this index is unable to differentiate the degree of congestion after a pattern suggesting congestion has been identified. More precisely, it cannot differentiate between mild and severe congestion patterns, which is clinically important. A more recent quantification method has looked at the renal venous stasis duration and calculated the proportion of the cardiac cycle during which the renal flow is detectable. This has the advantage of not relying on the identification of a pattern, which may be subjective in some difficult cases. This score has shown more promise in determining the degree of severity after a congestive pattern has been identified. This is, however, an area of development. Let's now review some potential confounders. Cardiac pathologies should generally affect both kidneys. It is thus important to evaluate both kidneys, as unilateral vascular and structural problems can manifest with similar venous profiles as cardiac venous congestion. This is well seen in these two sets of images that illustrate unilateral findings related to an urological obstruction. Unfortunately, it can sometimes be difficult to see both kidneys well enough to have a reliable tracing to analyze. In these situations, the tracing may appear discontinuous but this may be related to poor tracing quality, which may confound proper interpretation. One noteworthy finding is that diabetic chronic kidney disease only slightly increase venous impedance, but overall, continuous flow is present in most diabetic and non-diabetic patients. In these situations, the venous profile currently appears to be reliable to assess for right atrial pressure increase. Additionally, the presence of severe chronic kidney disease increases the difficulty of the assessment due to renal atrophy. It also may affect venous doppler profiles, although data on this phenomenon is scarce. Intrathoracic pressure changes represent a complex heart-lung interaction. This mostly results in increased right-sided pressure from changes in transmural cardiac pressures and pulmonary resistance. Consequently, positive pressure ventilation itself may worsen venous congestion, resulting in increased Doppler pulsatility. In fact, it may identify patients more at risk of abnormal right-sided pressures under specific conditions. In some cases, this can be inverted, as in this example where extubation actually worsened the pulsatility. It is likely that the intrathoracic pressure was impeding some venous return, which was actually favorable for a dysfunctional RV.
Clinically, it does appear that therapeutic maneuvers related to volume expansion, volume reduction, or arterial reduction may shift the flow to and from a discontinuous monophasic flow. The caveat is that it is unclear at times if other confounders are at play, such as time and spontaneous worsening and improvement. In patients with normal hearts, however, this does not appear to happen. An important point that this highlights is that there is no well-defined intervention that corresponds to a specific profile. Some patients will benefit from arterial reduction, some from inotropy, and some from volume management. These do not necessarily go hand in hand at all times, particularly in chronic pulmonary hypertension and postoperative cardiac surgery patients. In terms of evidence, intrarenal Doppler venous congestion is associated with clinical features of systemic congestion. There is a strong association with renal perfusion pressure. It is associated with NT-proBNP measurement after cardiac surgery. It is also associated with echocardiographic parameters of systolic right ventricular function. In the setting of congestive heart failure, alterations in intrarenal venous flow patterns are strongly associated with short-term prognosis and diuretic resistance.
In the next section, we will discuss intrarenal arterial assessment. Intrarenal arterial assessment is overall a newer technique in the realm of critical care medicine. It is the area where the most uncertainty and most research is yet to do. The key difference in the intrarenal arterial Doppler compared to the venous is that there are not multiple profile patterns that can be qualitatively assessed to determine pathology. Apart from the resistive index, arterial Doppler is sometimes quantified using the pulsatility index, which uses the mean velocity as the denominator. Currently, there is no specific benefit identified between the two, and clinical correlation is not well established.
Overall, in theory, increasing renal blood flow should lead to a decreased resistive index. This is regardless of whether this is due to isolated right-sided pressure increase or overall decreased cardiac output. Renal resistive index is not simple and probably a misnomer. Indeed, it is not simply resistance that is at play, but also overall flow that gets to the kidney. It manifests as a balance between upstream pressure and downstream pressure, with both affecting the overall flow through the kidney. Each are affected by a multitude of subfactors that are not easily integrated. This includes simple interstitial edema, which may be related to a structural or medical pathology. It may also be related to inappropriate vasoconstriction that may be iatrogenic in nature. It can also be affected by macrovascular occlusion from microthrombotic disease, as an example. In reality, pure physiological and pathological findings is only the tip of the iceberg. Inter-individual differences are already marked in healthy individuals, with unknown variability amongst critically ill individuals. Inter-observer variability is also not negligible, but may be mitigated by serial measurements over the course of illness. Acute kidney injury itself, whatever the cause, can increase the renal resistive index on its own without a clear correlation with increased right-sided pressures. Finally, an increased renal resistive index does not necessarily mean that the renal blood flow is poor. Indeed, remember that velocities and flow are related, but the flow is highly dependent on overall cross-sectional area of vessels. As such, lower velocity does not necessarily mean that there is less flow to the kidney. To better illustrate this point, carefully assess the tracing of renal artery stenosis. In this situation, the peak velocities may be decreased, with diastolic velocities being maintained. This may mimic the appearance of a normal intrarenal arterial flow. Another possibility is a low cardiac output state. This may appear with a similarly normal profile, particularly if associated with increased right-sided pressures. This is the end of this video tutorial on intrarenal Doppler flow patterns. Feel free to contact us through our Twitter accounts with any questions or comments.